The patient is placed in the lateral decubitus position, with the affected shoulder oriented upward. Using a balanced suspension system with 5 to 10 pounds of traction, the operative arm is placed in 30 degrees of abduction and 15 degrees of flexion to optimize intra-articular visualization. 3 portals are established: posterior viewing portal, anterior working portal and anterosuperior lateral portal. The posterior portal is established 2 cm inferior and 1 cm medial to the posterolateral acromial border. The anterior portal is positioned midway between the coracoid process and the anterolateral acromion. Angled toward the bicipital groove, the anterosuperior lateral portal is established 1 cm lateral to the anterolateral acromion edge. Tendinopathy of subscapularis tendon is visualized via the posterior portal. Adhesions and scar tissue around the subscapularis tendon are released using a radiofrequency device and arthroscopic shaver. After exposing the lesser tuberosity, the lesser tuberosity footprint is debrided and decorticated with a burr. A fish mouth tendon dilation technique is used to make a controlled longitudinal split in the subscapularis tendon at the footprint. A 1.6 mm V-lock all suture anchor is placed through the transtendinous pilot hole. The anchor is deployed through the guide device under direct visualization, ensuring sutures pass through the tendon substance. The torn subscapularis tendon is elevated with a probe to expose the anchor root. One limb of the suture is retrieved between the tendon and anchor's root, with a suture grasper through the anterosuperior lateral portal. An intra-articular loop is created without externalizing the limb outside the joint. Through the same anterosuperior lateral portal, the suture grasper navigates through the loop. The part beyond the tendon of the same suture limb is grasped outside. A self-cinching lasso loop construct is completed entirely within the joint.